Good morning, everybody, and welcome to NHS Digital's first full digital breakfast. It's the first of a series of webinars which we're going to be running in order to have a look at how digital technology has responded to the pandemic here at NHS Digital, and how, working with our colleagues across the system, we're supporting the whole of the NHS in responding to the pandemic and restarting and moving forward. So today's session is going to be discussing the 111 service and how 111 has evolved through the period of the pandemic to incorporate new functionality and new capabilities and support new services. So I'm very pleased to welcome our presenters from NHS Digital, who are led by Lowry, our Director of Digital Transformation, and Jonathan Benger, our Chief Medical Officer. We also have a number of panel members from our partner organisations across the system. So with us, we also have Ian Pickles, the Director of Urgent and Emergency Care Transformation at NHS England, Dr. Gareth Stoddard, the National Clinical Lead for Urgent and Emergency Care at NHS England, and Jackie Jędrzejewski, who's the Clinical Lead for Digital at NHSX. They will be taking part in a panel discussion, which will follow our presentation about the work of the 111 team. So to talk about 111, let me hand over now to Mandy Williams, who's the lead for our Pathways service.
Good morning. For those of you that don't know about NHS Pathways, it's a clinical decision support system, or a triage system, that supports the assessment of patients calling the NHS 111 service, and it also covers half of the 999 ambulance services in England. It also supports clinical assessment services, and it can assess patients in face-to-face settings, and it powers 111 online. Like everyone else involved in the NHS, it's been a really busy year. At the beginning of the pandemic, back in January last year, we were supporting 111 and 999 providers with updated guidance and information on system use based on the range of countries, towns, provinces and countries, hotels and various cruise ships that were affected at various stages of the contained phase of the pandemic. We were ensuring that those with symptoms of concern were managed by clinicians in the service, given at this time this was a new novel virus. As more became known, though, and a stable case definition of symptoms was agreed, we developed full system releases incorporating full health advisor symptomatic assessments into the core clinical content. We continued to iterate those rapidly as changes happened. We continued to make changes to support the ongoing pandemic response, such as our recent release, which contained enhanced content for those calling with potential vaccine side effects. And throughout the pandemic, the team have continued to update the core Pathways content suite and have reduced pressure on operational services by making changes that benefit patients and support operational priorities. Throughout the pandemic, we've also supplied aggregated data on symptomatic triages to support the monitoring and management of the wider pandemic response, because calls to 111 and 999 are often a really early barometer of what's happening of symptom prevalence in the wider system. This data has been published as open data on the NHS Digital website, enabling interested parties to use it and analyse it by downloading it from the web pages. We've also produced bespoke reports for specific use cases, such as recent reports of callers calling with potential vaccine side effect symptoms. Pathways is a licensed product, and at the start of our pandemic response, we looked at how we could make a range of license easements to support 111 and 999 providers operationally. We enabled a range of easements, including allowing health advisors who met a set of conditions to work remotely if required. And this meant that those employees who were self-isolating but were otherwise well could support the service by assessing callers from home rather than needing to be in the call centre. And thanks to the foresight of the Pathways training team pre-pandemic, we were also able to make a wide range of our previously classroom-based training courses remote or Teams delivered. And we provided a range of our training as e-learning rather than classroom-based learning. This allowed 111 and 999 services to employ new staff and train them in the ways that best met the needs of the service and complied with social distancing measures. We've developed a range of new products in the last year too. So PACS is our Pathways clinical consultation support product, and it's been designed to support clinicians during a consultation with a patient and is used as an aid memoir. The product uses existing Pathways content in a consultation style format, and it also supports clinicians to dispatch an ambulance if needed. It searches the directory of service, and it produces a suite of home care advice. And we also developed an injury assessment product, and this allows service advisors to triage injury-only calls following referral from a health advisor. The product was developed to safely assess injury calls and increase capacity in the 111 service by streaming the 10% of calls that are about injuries to staff who've been trained to specifically use this module. And finally, in the past year, Pathways has been used to triage nearly 19 million callers, with a chart on the right showing the disposition split for April of this year. Thank you, and I'm now handing over to Debbie to talk to you about the 111 online response.
Thank you, Mandy. Yeah, I'm here today from NHS 111 Online, and I'd like to take a look through how the team and the service responded to the coronavirus pandemic. Our journey starts back in February 2020. The backdrop was that public concern was growing around the emerging virus, and the 111 telephony service was experiencing exceptional demand. It was increasingly apparent that a digital response was required that could provide the general public with information and support. We met with NHSX and NHS England colleagues in early February to understand and scope out what we could deliver on the 111 online platform. So while we were working at pace to develop that service, we produced a banner which featured on the top of each of our pages. Initially, the banner was there to direct you to government.uk web information and Public Health England information. On the 26th of February, after a very frantic 2 weeks, 111 Online released the COVID mini service. The service initially supported the contain phase of the government response and of the disease, and therefore asked questions on travel and contact. And as much as Mandy said, that was continually changing. So the service went through multiple releases and changes to keep it up to date with the case definition. The service was also used by call handlers within the COVID response service. So during early March, the government began introducing the digital access points to their COVID advice. So most prominently, the NHS website featured on the newsroom lectern, and signposting to r111.nhs.uk service featured in their speeches and widespread across the media. And the impact on our service was huge. Demand went up 80 times and hits on our service were phenomenal. We responded by bolstering up our infrastructure to deal with this unpredictable and often unanticipated demand. We then introduced clinical symptom checking to the service in mid-March to support the government's delay phase. The service began reflecting more the core 111 online experience with signposting to clinical callbacks and call 999 and self-care advice. And it also featured links out to coronavirus services, other digital services like the SMS text message check-in, and the isolation note service, and also continued to link out to nhs.uk web content. In June, the mini service was removed essentially, and questions on symptoms were brought into the main 111 online journeys in line with NHS Pathways releases. The user interface for 111 Online still to this day recognises COVID and signposts the user out to relevant COVID advice. As you can see on the graph, demand for our service peaked in March 2020, but the service has continued to have increased demand and has continued to add resilience into the urgent care system. Overall, the service has provided greater resilience to other services by taking some of that traffic. It's given the public trusted and reliable and up-to-date care advice on their symptoms, and it's also provided Public Health England with general information on health incidents. So thank you very much for listening to me, and I'm now going to hand it over to Adnan Riaz, who's going to talk about 111 to ED.
Thank you, Debbie, and good morning, everyone. I'm Adnan Riaz. So 111 to ED national capability, just to give you some context, I remember the date and time. On the 24th of July at 1 o'clock, we were asked to look at 111 to ED national capability. So what that meant is that any 111 provider, including 111 Online, can book a patient an arrival time at any ED up and down the country. And the idea behind that is to reduce overcrowding and therefore reduce the risk of infection. Before we sort of looked at the project, we had to understand the IT and provider landscape, which is quite complex. Within 111, you've got 4 IT suppliers plus 111 Online. 4 IT suppliers and 111 Online, and you've also got 24 different providers. Within ED, it's actually more complicated. You've got 20 suppliers, 30 different pieces of software, and over 170 different EDs. So what we did is look at 2 pieces of work in parallel: so strategic direction and building a system. So strategic direction was to allow system-to-system integration. So users at the ED and 111 didn't have to log into a different system. And we were using national standards such as Care Connect for booking and 111 ITK for referrals to allow that process to happen. Knowing the digital maturity was varying across the area, we also decided to build an application called EDI, Emergency Department Digital Integration. That was a standalone, secure via smart card web-based application that let users of the ED add their slots that were shared with 111, also see the referral information that was arriving. So during August, we completed some user research and service design, and this was in parallel to building the product. User research happened by speaking to various users up and down the country in EDs to understand their sort of pain points. And obviously this was a new process to them, so we were mapping out how referrals will come in, how booking would go in, and we designed a service blueprint to help for informed development and also help inform policy decisions. In August, September, we started building the EDI product, and we used something called rapid prototyping. So this is where we created some wireframes, some early drawings, mock-ups, shared that with users at the ED, obtained feedback, and helped us deliver a new module. And the team were actually building and delivering a product every 2 weeks to hit our deadline of 1st of December for all EDs going live. We knew there was a massive business transformation element here. So we created a toolkit for regions, and what we did within the toolkit, we had swim lanes with responsibility. So we knew what 111 Online had to do, we knew what DOS had to do, EDs had to do, 111 providers, and we drew the process end to end. And we used our first of types to actually understand the process to make sure it's correct. And we iterated this throughout October and November. We also created a public-facing website. The website included information such as how to set up your smart card, how to use EDI videos, any sort of frequently asked questions, access to the service desk. And as we were going live in November and December, we had drop-in sessions. So we had a drop-in session every day with the techies, so anyone for the trust could come along and ask us any questions. During October and November, we had to ensure that 111 suppliers and providers were ready. By the 1st of November, 99% of 111 suppliers had developed against the Care Connect booking standard. And we also then tested 99% of 111 CAS providers straight into EDI to make sure the end-to-end journey worked. And it was quite amazing. Within 14 weeks, we actually delivered that capability. So an example here, we've got 111 Online, where a user or patient could, do some triage, select an ED. They had a list of appointments in the middle, so they selected their arrival time, and it goes straight into EDI. We actually worked with two first of types, one being Yeovil and the other one in Hull. And you can see some quotes from Andrew Cook from Yorkshire Ambulance Service and Alistair from ED. And overall, it was very positive. They're really supportive of the IBC team that we had deployed in every single region. And Alistair within the whole ED, it was quite good on the first day, We tested it, we went live, and they actually received 111 online referrals and booking, straight away. So it was a really full digital offering they were providing. During sort of December, the product was updated every 2 weeks, and it was updated until March of this year. And some of the key features you've got here is, allowing you to allocate capacity, automatic DNA feature. So if the patient doesn't arrive after 75 minutes, it automatically allocates them as DNA. You can also have a DNA list where you can change the status. You've got the patient shielded status, you've got reporting and workloads and dashboards, and you've also now got the ability to automatically email you a daily report. In January, we were live with 80% of EDs, and the chart on the left shows you that 130 EDs were using EDI with a Care Connect functionality, 11 EDs were using their own system with the Care Connect functionality, and this supported the strategic direction. 37 were using a more localized solution. By the end of March, 145 were using EDI and 11 the strategic solution, which got up to 88% of the country using the national capability. And I'm just going to pass you back on to Mandy.
Thanks, Adnan. And so finally, in support of the 111 First campaign, the NHS Pathways and 111 online teams worked together to deliver a new product to enable patients presenting to urgent and emergency care services, such as EDs or UTCs, to use a self-assessment tool via a tablet in the ED. It's a user-facing product aiming to safely identify those unheralded patients that need to be in the ED or UTC, and those with lower acuity illnesses or injuries who could be treated elsewhere. It enables an equity of assessment to those who are heralded via the 111 service. The streaming and redirection product assesses walk-in patients and directs them to the most appropriate care setting, either inside the ED or UTC, elsewhere in the hospital, or to another service that's been profiled on the directory of services by the local provider and commissioners. And this may not be the service that they're attending. The patient may be directed to more appropriate clinical settings if they're required to do so. We've just finished the piloting of the streaming and redirection tool. It's been really successful, and we're now looking to roll out to, at the moment, 30 EDs and UTCs have expressed interest, and we have 5 going live in the next month. That's it from us today, so I'm going to hand you back to Matt.
Thank you very much to all of our presenters. First of all, apologies to anybody who's having or had difficulty getting in this morning. Teams has updated with a new feature that may be a bug, but I think we're battling through that. So now we're going to move on to the panel discussion. You will find that you can submit any questions in the Q&A channel, and we will take them, pass them to panel members and publish them. So now's the time to start typing in those questions. I think I'll just start by asking each of the panel members to introduce themselves and also speak a little bit to one of the first questions that's come in, which is, what has COVID taught us about digital responses? So perhaps I could start with you, Jonathan.
Yes, good morning, and thank you. My name is Jonathan Benger. I'm the Interim Chief Medical Officer for NHS Digital. I've been providing clinical leadership to the organisation throughout the pandemic. So I think, reflecting on the presentation, there are a number of key elements that we've demonstrated really throughout the response to the COVID-19 challenges. So that's the ability to work at speed. And I think many of our processes have been accelerated. It's not so much that we've done very kind of different or new or radical things, but we've accelerated our opportunities for change and our ability to respond to requirements. So a lot of what we had envisaged would take perhaps years to achieve has been achieved in months, and also an element of flexibility in responding to both the kind of the pandemic itself and policy, which has had to be very rapid in its response. So I guess the the overall summary of that is that we have demonstrated that what digital technologies can do is they can support that response, they can be flexible, and they can be deployed at speed, at a greater speed than we had ever thought possible. Mandy's alluded to some of the early stages of the pandemic where we were making very rapid changes, sometimes several times a day, to our products and services in order to keep up with developing events. And that also meant that the public got used to the idea that that was where they could go to for up-to-date advice and support. So that provides a very swift and very effective platform, which I think has responded very effectively across all of the suite of products that we've described this morning.
Thank you, Jonathan. So let's move on to Jackie. What are your thoughts on digital and the pandemic?
Good morning, everybody. So I'm Jackie Jędrzejewski. I'm the clinical lead in the digital urgent and emergency care team, which is part of the digital transformation team within NHSX. And just in case anyone isn't familiar, NHSX is the joint unit between the DHSC, NHS England, NHSI that's leading the digital strategy for NHS and social care and supporting clinical teams. I think, as my colleagues and Jonathan and Mandy and Debbie and Adnan have sort of said, this past year, gosh, what we've achieved in months has really helped us understand how we can maximise the benefits that digital technologies can bring. And I think thinking about not just patient care, but also helping and supporting the workforce, bringing in digital innovations, updating tech. Sometimes it's not necessarily about something new. It might be about updating things we have. And bringing in solutions, and the team worked around the clock, especially in the early days of COVID, to do what we could to help support, as I say, patients and the workforce. So for me, this is about the digital foundations, evolution of digital technology, and then eventually whole system transformation.
Excellent, thank you, Jackie. Gareth, maybe you'd like to share a few thoughts.
Hi there, yes, I'm Gareth Stottard. I'm a GP in Birmingham and I'm the National Clinical Lead for Urgent Emergency Care for NHS England, which covers IUC, which is the 111 element. So it has been a very busy year for me with the evolution of 111 through the course of the pandemic. I think in terms of the digital response, I'd divide it into the response phase that we've had, and now as we're entering it into more of a recovery element. People have touched on the rapidity of needing to change the clinical assessment tool, but we also had to look at how we could deploy huge additional numbers of both call handlers and clinical resources. And just put that into context, we had probably at the peak, we had 5,000 additional call handlers that were working off of a single national queue, which patients arrived at that through an IVR following calling 111. We had a national clinical resource of in excess of 700 GPs who were all working off a single queue. They had the functionality to prescribe, to view the patient record, and to refer on to any of the dispositions that are available through the directory of service. All of these things were elements that we had thought about, but as Jonathan said, it's the speed of deployment of those during the pandemic that's been important. And now as we move into more of the recovery phase, it's seeing the increased linkages between 111 online, EDs, the telephony service, and the development of additional functionality, things like NLP, just evolving now to look at how we can start to take demographics from patients, how we can have enhancements of access to the record and see the full encounter history. I think all of this has been a huge acceleration and has been is a good element that has come out of the COVID pandemic.
Thank you very much, Gareth. I'll come on to Ian Pickles.
Good morning, everyone. My name is Ian Pickles. I'm Director of Urgent and Emergency Care Transformation at NHS England and Improvement. Within NHSE, I am the SRO for 111 and Integrated Urgent Care. I think, as others have said, I think probably the single most impressive thing about the digital agenda throughout the course of the pandemic has been the pace of change, and that really is testament to colleagues across NHSD, NHSX, and well, across the wider NHS, really, in terms of how quickly things have been able to be done. But I think the other lesson that we need to reflect on is is around digital exclusion, actually, because we've always been slightly nervous about disenfranchising people by pushing digital services too hard. And actually, I think what we've learned is that whilst we need to make sure that we have the capability to offer services to absolutely everybody, digital is the channel of choice for the vast majority of people, and we can see that in the services that we've created and stood up throughout the course of the pandemic. So we shouldn't let fears of digital exclusion hold us back from really pushing forward on the digital agenda.
Excellent, thank you, Ian. And finally, Ian Lowry.
Good morning, everyone. I'm Ian Lowry. I'm one of the delivery directors in NHS Digital that looks after the urgent emergency care portfolio. I think sort of building on what everybody else has said, I think there's probably 4 or 5 points. Working at pace, I think that was probably one of the biggest challenges that we had, working at pace. But it also brought together, I thought, a really good focus of multidisciplinary teams working to solve a common problem. The other thing, point is touched on by Ian, is it was a great time for system cohesion, enabling sort of quicker service transformation, everybody working together. I think there's also something to be said about the impact on staff. This has been quite relentless for staff, constantly working at such a high pace. And I think it's good to realise that what's different through this pandemic was that we had different ways of working. And it's really interesting that a lot of this work has been done whilst a lot of people have been working from home and having to adjust to a different way of working. They'd be my observations.
Thank you very much, Ian. Right, so we'll move on to some more questions. I'm not going to propose that every panel member answers every one from now on. So the first one we'll pick up is, has 111 changed the way that patients behave and improved what they expect from services? So I think probably I'll come to Jackie on that one, possibly followed by Ian Pickles.
Thank you. So we had an initiative that was referred to as 111 First, and this was a campaign to encourage patients to contact 111 before taking themselves, for example, off to ED. And I think that's been broadly successful. I think we saw, for the first time probably in our history, everybody that's joined this morning, changes in behaviour throughout COVID last year. People were asked to stay away from hospital, and in fact they did do in their droves. And then we started to see in between lockdowns people returning to use care as they'd previously experienced. But I think what was different this time is promoting that message, you know, contact 111 first, and having the ability to book patients in some situations into direct care has been beneficial for them. And I think something we must never lose sight of is patient satisfaction measures in relation to 111, which are really good, really high. Do we get it right all the time? No, certainly not. Do patients have a good experience of 111? Yes, mostly they do. And when things do go wrong, obviously we can all work together to look into that, learn from that, and make things better. But I think behaviour has changed in this last year, and I think the 111 First campaign has certainly helped achieve that.
Thank you, Jackie. Ian.
Thanks, Matt. I'd echo what Jackie said. Really, it's difficult in many ways to disaggregate kind of what's the impact of 111 specifically on the public's behaviour versus what is what's been the wider impact of the pandemic. Clearly, 111 has been much busier, both through the telephony service and online over the course of the last 15 months, and that is in part linked to people's reluctance to go to face-to-face healthcare settings. What we can see now as we move out of the initial response and as we come out of the winter wave, though, is we think that actually there are some fundamental shifts in the way people access 111. With, you know, historically it's been very much an out-of-hours service, and calls into it, and when people use it online kind of reflects that. But actually, as we've moved into this recovery period, we seem to be seeing a sustained shift in when people access the service, and it is much more of an in-hours service for the general public now. So I think it's going to be interesting over the course of the next 12 months to see to what extent some of these changes in public behaviour stick, and to what extent some of those behaviours go back to historical norms. And I think from a policy perspective, you know, there is a challenge and a question for us to answer, which is, to what extent do we want public behaviour to go back to historic norms, or do we actually want to try and reinforce the behaviours that we're seeing now in some ways through our policy?
Excellent, thank you very much, Ian. I'll now come on to a couple of questions that are linked together. Do you see these capabilities sustaining post-COVID, or do we think that clinicians will go back to previous ways of working, and how do we see it developing further? I think I'll come to Jonathan first on that one and then follow up with Gareth, if that's okay.
Yes, thank you, Matt. I mean, that follows on very nicely from the previous question. I mean, I think the challenge is to get the balance right. So before coronavirus, I think we were challenged to move consultations where appropriate into alternative channels. So, we were looking for ways to support users to access services digitally or by telephony rather than through traditional face-to-face methods. With coronavirus, almost overnight, we shifted a lot of our service to kind of remote and digital provision. And now I think the challenge that we have is to find the right sweet spot between the kind of where we were before coronavirus, which I think didn't adequately utilise digital technologies in an efficient way to provide effective services, to the kind of height of coronavirus, where I think we all acknowledged that there was a risk that patients wouldn't access services effectively, particularly those who are from more disadvantaged backgrounds, to where we need to get to, which is about how both clinicians and patients behave in the future. So I think we've demonstrated how much can be done through digital technologies, and we need to retain the best of that. But we also need to make sure that we don't disenfranchise vulnerable individuals, and we also need to make sure that we get the balance right between remote consultation and face-to-face consultations. And so I think that's exactly where we are at the moment. We're sort of working through that process to get it right. There are a lot of efficiencies in digital consultations. Much work does not require a face-to-face encounter. It can be done very effectively and with high levels of satisfaction through remote means. But some of it, of course, does require that. And maintaining relationships, for example, in primary care, ensuring that we provide an equitable service for the entire population requires us to find that sweet spot between a service that is largely kind of digital first, but which is backed up by more traditional methods of consultation, which ensure that the whole population can access services effectively when they need them. And I think that we are working through that process right now, both in terms of trying to address the backlog of work that has inevitably accumulated during the coronavirus pandemic, and also getting the balance right. So we need to learn from the experiences of coronavirus, and I say we need to take the best of what we've achieved, but we need to get that balanced right so that the services that we provide reach the whole population and do so in a way that's as efficient and effective as it can be.
Thanks, Jonathan. Gareth?
Yeah, I think through the pandemic, we've seen that a large proportion of the population, including my parents, have become far more digitally able than they were previously, and utilising things like remote consultations, which they would never have considered previously. People have warmed to those and embraced the new technologies. Working as a frontline clinician myself, I can see that it is, as Jonathan says, about finding the balance. It isn't always about simply needing to touch and feel a patient. Sometimes that human contact that you get in a face-to-face consultation can bring out a lot more than you can remotely. It's finding the consultations that it works for, finding the means to do it, things like the video consulting, the means to get observations where possible. But it is finding that balance of face-to-face where we need it, but embracing technology and embracing the new thinking and the new accepting from patients and clinicians to move forward with the digital agenda.
Thank you, Gareth. Question now, I think, for Ian Pickles, followed by Ian Lowry. What have you learned about the pace of change that the urgent emergency care system can sustain, and how can we match the pace of digital delivery to the appetite for adoption? Interesting one.
Thanks, Matt. So I guess in one sense, it reinforced something that I already knew, and kind of coming from an urgent and emergency care background, or having worked in urgent and emergency care throughout the vast majority of my career, I think I've always been aware that urgent and emergency care services are able to be incredibly responsive and incredibly reactive to changing situations, and that's always been the case. I think the pandemic has really reinforced that. And it has to be acknowledged that actually the scale of change that urgent and emergency care services has had to go through was completely unprecedented, certainly during the course of my career. So I think the challenge now is, given just how rapid that has been over the past 15 months, the question of how sustainable is it for the people who work in urgent and emergency care services really has to be front and centre of our minds. Clearly, as we move into the recovery phase, there is going to be more change, but we need to, as quickly as possible, return to some kind of normality and some kind of business as usual, because whilst the ability to change at pace is absolutely essential, I don't think it's necessarily kind of healthy for everybody working in that environment for it to be kind of never ending at the pace that it has been.
Thank you. Ian Lowry.
Yeah, there's not much more to add to what Ian's really said. As someone who's sort of new to this area, I've been well impressed by how suppliers have adapted to make the necessary changes, and also working on some of the service transformation, especially with the ED product. It's been amazing that in some of the ED departments, how during a pandemic they've embraced the technology and the service. That's probably what I would say. Okay,
thanks very much, Ian. I'll stick with you and the team for this next couple of questions, which are: how did you align ways of working across multiple teams to deliver effectively at pace? And from a delivery perspective, what are the key lessons you take away? So very much about delivery here.
Yeah, so yeah, we did change a lot of the ways of working. It's a bit probably overused for us to say the word agile. It's about creating that environment for the teams to to flourish. I think one of the things that we probably did, which enabled things to move at pace, was we changed how decision making was done. Because getting quick decisions was really important, we formed multidisciplinary teams really quickly, so everybody was involved. There was no shocks. We had obviously, as you expect, the sort of daily stand-up. I think which was different was that governance and decision makers were part of those stand-ups and were part of a sort of weekly product board that we had that brought in all parts of the service. So that's how we had all of the teams working together. I think in terms of delivery, as was alluded to by Adnan, I think a lot of the work that we've done, and with Mandy, is a lot of rapid prototyping and testing. Because it was quick delivery, I would say though that people are saying, is this sustainable moving forward? I mean, the teams are pretty tired, and it's been quite hard work at the pace of change. So that's what I would say. I say the team's coming together, quicker decision making, and everyone being really focused on an end goal.
Mandy or Adnan or Debbie, do you want to add anything to that?
Yeah, I agree with Ian. I think it's a lot of things. It's like communication. So I like the phrase radiating. We were doing show and tells every few weeks, and we had hundreds of people there, and we were just showing, this is what we're doing, this is how we're going to achieve it, this is what we're doing it for the greater good. And as Ian said, the board was a really fantastic idea. It's a weekly board. We had all the key stakeholders, and I would say 95% of the decisions were made on the day, and if they weren't made, they were made on the Monday after. So these quick decisions helped us deliver at pace, and I think that's one of the things I'm carrying on to all my projects, is that same ethos of working across different organisations and teams.
Thanks very much, Adnan. So a question that I think probably for Jackie to start with: how does the streaming and redirection tool manage the views of ED staff that once patients step into the department, they are their responsibility, and there's too much clinical risk if they're told to go elsewhere?
So
and then probably Jonathan afterwards.
Okay, so the ED streaming tool, and this is why we when our systems are designed, they're then tested. And they're tested because when we start with any idea or any approach, and you start drawing that on a piece of paper and you build around it, along come these enormous questions. And if we're not careful, we'd make ourselves too nervous to ever try anything and take that very first step. And ED streaming was a classic example of this. And in fact, over many years, we've tried all different types of or forms of ED streaming, and never really have they taken grip. And I think this time it is. So what I would say is each area works through their clinical safety, exploring the clinical safety around the use of the tool, as you would expect, and also the operational requirements in that unit. So when we started talking about the ED streaming tool, initially we were going to have the very most senior clinician, probably Jonathan and Gareth personally there overseeing every patient to make sure we got it right. But in the real world, of course, that isn't practical or possible. So we have to think about trust in the system and the clinical governance that's behind the system it's built and how it's supported. Making sure that clinicians are on site to be able to see patients. So, for example, if you had a youngster under the influence of alcohol, somebody gave an example yesterday, who's clearly pretending to be a little older than they are, you would want someone to physically be able to see that that is not the scenario that's being presented in the use of the tool. So, sorry, this is really exciting area for me. I could talk about it for hours, but in essence, this is for each area to use the system, explore the governance that they want to put in locally around that. The areas where it's in use now, there are clinicians present to support patients, and we're calling them care navigators. It's a care navigator type role in the use of the tool. I think it's fair to say for some patients who may have turned up at ED and expect to be seen in ED, and they've paid to park their car, to then use the system willingly and happily, people are happy to use it, but then perhaps to be told that they don't need to be there, and in fact they could go and see their primary care team maybe the next day, or go to another team. For one or two patients, that's a step too far there, and as I say, they've paid for their car park, they're not happy about that. But by and large, if the offer is better to patients, they get a good experience and they get seen more promptly, then patients are benefiting from that experience. And the staff seem to really be supporting this, because it's helping them manage their department as well. So if anyone hasn't seen it, there is actually, I don't know if we're able to put it in the chat. Mandy will probably be able to work some magic and do this. We actually have a video that I would encourage everyone to have a little look at, that really explores the ED streaming tool, and also connections to contact people to get more information. Hope I've answered that. As you can tell, it's an area I'm quite passionate about. ED streaming and redirection is the way to go.
Thank you very much, Jackie. Jonathan, do you have anything
well,
to add to that passionate?
Yeah, it's hard to follow such passion. So many of you will be aware that I'm a emergency medicine consultant in Bristol, and so I'm very aware of the challenges here. I think the first thing to say is that it doesn't change the fact that if the patient is in the emergency department, then they are the responsibility of the emergency department and the acute trust behind them. But the point here is that this is a tool that we're offering that's being carefully tested and rolled out in a progressive and staged way to try and support decision making at the front door. We're all aware that the demand in emergency departments is high at the moment, and many staff are looking for ways of managing that demand in a safe and effective way. So the way I would see this working is very much as part of a broader strategy to safely and effectively manage demand. Certainly in my department, we've got some very long waits at the moment, and that's not in anybody's interest. It's not good for patient experience. It also increases the risk of transmission of disease, which has become a much more important consideration. And so the opportunity to effectively identify alternative services which meet the patient's needs in a more timely and appropriate way is here to stay. It's part of the ongoing work of emergency medicine. So this tool is part of the armamentarium, and each department will want to think about how they want to integrate that into their systems, how do they integrate that into that flow, and how do they reassure themselves that the service that they provide continues to be safe and effective and meet the needs of all patient populations. Very importantly, emergency departments provide a safety net as well for the most kind of disadvantaged in society who struggle to access other services, and so it's really important that we retain that function And as Jackie's described, this work is backed up with skilled clinicians to ensure that we don't overlook vulnerable individuals. And that we use this particular additional digital tool safely. But the work that we're doing shows quite clearly that it can be integrated into emergency department flow and practice in a way that supports staff and improves the overall delivery of the service. So let's say each department needs to work through this, but so far it's looking extremely positive as we gradually, progressively and carefully develop and test this service.
Thanks very much, Jonathan. Moving on to a slightly more general question, I think, which I'll come to Jackie with first, and then possibly in Lowry, about the evidence and user insight we have that people are starting to prefer digital services, and what do we have now, and what are our plans for getting more user insight going forward?
So I would say this really is about using the data that we have to intelligently commission services fit for the future and in response to patient need. I think over the years we've learned that people have preferences for how they come into services, and not a general rule, but as an example, often when people are very unwell, very poorly, they'll contact 999 by telephone or 111, but when they're seeking information for maybe a lesser symptom or a lesser condition, they might first go to 111 online or nhs.uk or indeed the NHS app. But we've seen through COVID that those behaviours have changed a little, and that actually people access urgent care also using the app nhs.uk and NHS 111 online. And so, as you would expect and hope, we all work very closely together and use that data to really help us inform how we can improve patient pathways, support alternative dispositions to urgent care, etc. But I think the best thing that's been achieved, and that we're working at pace to make as efficient and effective as possible, is that whatever entry point a patient chooses to come in, so whether that's through the app, through the telephone, online, using a handheld. I've sat on the train, in fact, and watched people kind of assess themselves using the app coming home from work, and then which is good. But whatever route a patient chooses to come into the service, that service is then seamless for them. So if they come in online or they come in through the app but need to speak to a clinician, we've made that really easy for them to be able to do that, and just a click of a few buttons. And then, of course, importantly, what we want when they come through to a clinician is that they don't have to repeat themselves from the start. So that clinician has in front of them the reason for their contact and the questions that they've been asked and answered so far.
And can I just add to that as well? I think it's consistency as well, so that the assessment is consistent. So that if it's a digital or a telephony or a face-to-face approach, that if it's underpinned by the same triage system, then that means that the patient will always get a consistent response. And so what that means is that no matter where a patient accesses the urgent emergency care system, how they do that, the way that they are triaged and the kind of dispositions and the process that follows is always the same. And that means that the opportunity that patients have sometimes had to kind of shop around, but also the confusion that comes with multiple access points and not being sure which to access or how to access is substantially addressed. Because in effect, if a patient makes a choice that is unusual, and so with critical illness or injury, they contact one of the sort of digital services, we can still route them through to an emergency ambulance response. Conversely, if they contact the ambulance service with a very low acuity problem, we can effectively route them through to an effective pathway. And I think that's really critical, because it means that the patient always gets a consistent and correct response, and the services that sit behind it are entirely joined up. And that, I think, will be the key to getting the right patients to the right services in the right way. And one of the side effects of coronavirus is we've taken a huge step down that pathway, and we'll continue to do so.
Thanks very much, Jonathan. Ian, do you have any further thoughts on?
I just think, just building upon the 2 points, I mean, I think from a sort of IT delivery, service delivery aspect, it'd be true to say that we're using a lot more evidence-based, looking at the data, looking at the data quite a lot. I think we've had a massive move towards sort of user-centered design, service design, building IT systems that support the business needs. I think that's been really effective, and certainly some of the work that we've been doing very much focused on the sort of user-centered design, and of course getting feedback through satisfaction surveys and so on and so forth. Again, looking to continuously improve the services.
Excellent, thanks Ian. And sort of building on that, there's a number of questions with a lot of interest in the future roadmap for the next 12 to 18 months. So maybe I could ask Ian Pickles to pick that one up, followed by Gareth.
Thanks, Matt. So I guess the first thing to say is, in terms of the 111 First programme, which obviously we've been really keen to emphasise with the public as much as we can, particularly over winter, last winter, we want to continue to push ahead in promoting the concept of people with low acuity urgent care conditions ringing 111 first rather than self-presenting to emergency departments. So we're absolutely keen to continue promoting that. There is a large scale, there will be a quantitative and qualitative evaluation of the impact of the programme over the course of winter and into the beginning of this year, and that should be coming together towards the end of June, beginning of July. And that will be crucial in helping us inform our policy as we kind of move into the second half of the year. I think the other thing to say, though, is that we are keen to make sure that 111 is not just a conduit for patients into emergency departments, but also can properly link into all parts of the health and care system. So we really are keen to establish links between 111 and urgent community response. For those callers who need it, or those users online who need it, because actually we think if we can link patients into kind of rapid community response, that is currently a cohort of patients who at the moment often default to accident and emergency departments because the 111 can't properly link people through to the appropriate service. Another crucial one that we're really keen to progress as far as we can, both this year and in subsequent years, is making sure we've got really robust links between 111 and mental health services as well. And that's always been part of the long-term plan and part of our agenda around integrated urgent care. But particularly important now because we can see as we come out of the pandemic that actually there is a mental health demand or burden kind of out within the community, and we need to make sure we can get patients linked into mental health services as rapidly and as effectively as possible.
Thank you. And Gareth?
Yes, primary care ED 999 services, these are the trusted brands from a patient point of view. You know what you expect, you know where it is, and you generally know how to get to it. The challenge with 999 and EDs being that they never close, and there's no filter on the front door. What we need to embrace as a slightly looser roadmap is the navigation through 111 and IUC to the various other elements of urgent care that currently exist, and those that don't currently exist, we need to develop those. But importantly, we need to have the navigation through 111 and IUC to those services in a way that's better and simpler than a patient can manage themselves. We don't want to simply be putting hurdles in the way or steps in a process that a patient could navigate in exactly the same way. We need it to be better and easier so that patients will use it and therefore be exposed to the width and breadth of other services available rather than simply defaulting to their trusted brands.
Thank you very much, Gareth. I think we have time for one more question, so I'm going to ask a difficult one, but we'll have a short answer, which is, what have we learned from this? What would we want to build on? What would we do differently? And Ian Lowry.
Oh, thank you for that, Matt. What have I learned from this? Dear me, what have I learned? We've got some exceptional talent that have been able to adapt really quickly, and we've got some really strong products that have also been able to adapt to meet their sort of changing needs. What was the next part? Sorry, Matt.
it was what would we do different? What would we want to do differently?
What we'd like to do differently. Oh, it would have been nice to have a bit of sort of notice on some things and a bit more planning. That would have helped. I think it's been a really difficult. It's quite a difficult one, isn't it? Because no one's ever been through pandemics before, and how we probably want to have more time and to do things. But I think we've achieved what we've achieved because we've adapted to the circumstances of us, to be honest.
Very good, thank you. I'll put Jonathan on the spot for the same question.
So, I mean, I think we've learned a huge amount about what digital technologies are capable of and what we can do, and the requirement to deliver at pace, at scale, and under huge pressure has required us to step up to that. And I think we've built a huge degree of confidence and self-confidence in what actually we can do across the system and what digital technologies can achieve. And I think we've taken a big step forward in terms of integrating those technologies and demonstrating their value. So I think that's a huge step forward. I think the big challenge for us is about how do you sustain that? How do you get the balance right between, say, digital and more traditional kind of services, as we've already alluded to? And I think the other thing that we need to be very conscious of is that it has taken a toll on our staff. So it's taken obviously the pandemic's had a huge impact for frontline clinical staff in health and care, but also those people from the teams working behind the scenes who have also worked very long hours without a break to deliver in support of those frontline staff, have also given a lot. And so the future is very much around finding a sustainable position that balances the various elements of healthcare that builds on the best, but also recognises the staff contribution in order to ensure that we create something that's sustainable for the future.
Great, thank you very much, Jonathan. And anybody else want to come in on that?
I would only add, I feel a sense that we've all come together. I think the whole of the NHS, and I think the public, are behind the NHS, the public are in support of the NHS, and we've all come together. And as colleagues have said, a little more understanding or a little more notice at times would have been really appreciated. But we're where we are today, which is pretty incredible, because if we look back even a year ago today, would we have imagined where we are now? So it's been quite incredible in so many ways, notwithstanding the fatigue and the tiredness and things. But on a positive note, as I say, we've all come together. And I think if I had the opportunity to throw one question back, it would be: are we giving you what you need? Are we delivering what you need to support you? And our doors are open to tell us if there's anything you think we should know.
Great, thanks very much for that, Jackie. And on that note, I think it's time to draw the session to a close. I hope everybody's found it useful and informative and interesting. So first of all, thanks to Ian and the 111 team for doing the work, first of all, and their presentation. And secondly, thanks to all of our panellists, who I think have given us a really interesting and valuable discussion. So thank you, everyone.
Thank you.
Thanks. Have a good day.
Bye, everybody.
Thank you all.